Thanks so much, Sudar. That was a very kind introduction. It's so weird to be here without Vic Tepson being here, right? So actually, the first time I was here at this symposium was in 2009 when Vic was sort of running it. But I'm sure someone else was doing the work, probably Terry. Um, so let's talk about risk stratification, and I'm going to put my spin on it. Sudar already gave you a lot of the data, so I'm not going to belabor that. The first step in risk stratification was simplified at the World Symposium, and Dr. Chin will go over into that treatment algorithm in much more detail. But the first thing we have to do is say, is the patient at high risk or are they not? We don't really do low and intermediate risk at the time of diagnosis anymore because we treat them the same. So high risk, not high risk, with the little qualification that some people who are technically not high risk but have advanced hemodynamics or echo findings could be treated as high risk. And that's the orange people plot that Sudar showed you. So how do we assess risk? Well, there are lots of ways. We are in the US, so I'm going to start with Reveal, which, as you know, has undergone transformations over the years. But these are the data for the Reveal 2.0 calculator, which has 13 variables, some of which are non-modifiable. And that's a conversation that we've had many times in terms of risk calculators. And it's also been simplified into the Reveal Lite 2 version. And it is incredibly accurate. You can look at your Reveal score and predict what your prognosis is. So it's a very accurate tool to predict prognosis. And I'm not going to go into all the differences in bootstrapping and C statistics and this and that, but it's incredibly accurate. One of the criticisms that it came under was that there are so many non-modifiable variables, PAH, etiology, for example, sex, age. And as a target for treatment, you can't change those things. So we've had lots of conversations over the years about that. And Reveal to Light is a score that is based on 6 non-invasive and modifiable variables. So this is probably what many people use in clinic these days. This is what we use. And these are things that you get every time you see a patient. So it's functional class, hall walk, biomarkers. So you get that every time: blood pressure, heart rate, and kidney function. You draw blood, you get their vitals. You do this every single time in clinic. There should be no reason that you don't do a risk score at every visit. And it is delineated into low, intermediate, and high risk. So obviously a very good tool. The Europeans have approached it a little bit of a different way, and this particular table has undergone modifications over the years based on emerging evidence. And you all have seen this a million times. And these are factors that we think are associated with risk and the cutoff variables that make them low, intermediate, and high. And to do the high, not high risk stratification based on this, you just assign a point value 1, 2, or 3 for low, intermediate, high, add up the points and divide by the number of variables. And so you have the ERS, ESC, high, not high. And both tools are good, and you need to do them. Then the next time you do risk stratification, after the patient's been on whatever you chose initially for 3 to 6 months, and then essentially at every visit after that. And that follow-up is now in 4 different categories. And again, Dr. Chin will go through this, but one of the big problems we had with low, intermediate, high is that intermediate risk was so darn big. 70% of the patients fell into the intermediate risk group, and if 70% fall into one group, it's not a very discriminating tool. And so now we have 4 categories, and there is actually a huge difference between that intermediate low and intermediate high. So this was proposed first from the Compara paper, and it was validated in the French population. So it looks at just 3 non-invasive variables, again, that we get every time we see a patient in clinic: functional class, hall walk, and biomarker. And it assigns the cutoff variables that you see there. You give points for wherever the patient falls and then divide by 3. And it is incredibly prognostic. This is data from the Compara registry in the PAH patients, but the French registry essentially duplicated that at baseline on the left and follow up on the right. And you can see those four strata are different curves. So now we use that, which I think is incredibly helpful in clinic, because when you had an intermediate risk patient before, we knew there was a big difference in them. And, on the one hand, you could be talking about parenteral prostacyclins, and on the other hand, you could be talking about, inhaled or oral prostacyclins. And so it really helps divide that group out more clearly. Now, as much as I think that's all very important, I think there are incredible limitations to the risk assessment tools that we use. And I think this is where we really need to go in the future in the next World Symposium. While all of those non-invasive variables, functional class, hall walk, biomarkers, heart rate, blood pressure, and renal function, correlate with the severity of pulmonary hypertension, they also correlate with a lot of other things like age and comorbidities. And we all know that we're seeing many older patients with comorbidities these days. So these variables, while they have prognostic relevance to PAH, they're also independently predictive of all-cause mortality. So are we really measuring the impact of the PAH? And as much as I'm grateful for the literature that we have, it's flawed. It's almost all retrospective. There's lots of missing data in databases. It's limited to specific PAH etiologies, and most of the data is based on 1 to 5 years of follow-up. And we know that we want to think about not just 1 to 5 years, but 10, 20, maybe even 30 years in some of our younger patients. The other problem is we don't really use risk assessment. These are data from a survey that really show that only 40% or that 40% of patients do not use risk assessment tools in clinic as much as we preach it and as easy as it is to do, and that their clinical gestalt is not very accurate. Their gestalt underestimates the risk. So that's also a limitation. Now, probably the biggest gap that I see in terms of our current risk assessment tools has to do with a couple of particular categories on either end, but these are not uncommon. Those are the younger patients who function well despite advanced hemodynamics and poor RV function, and the older patients who have multiple comorbidities who function poorly despite their pulmonary vascular disease being well treated. And, one of the sticklers for me is this hall walk, this 6-minute hall walk. There's this magic number, right? 440 is a magic number. What is magic about 440? It comes from databases of people with, lots of different characteristics. It actually first started, since Sudar and Terry and Jimmy were talking about the history of this program. The 440 started way, way, way back when in the early 2000s in a paper that Olivier Sitbon published on prostacyclin response, and 440 was the median, and they have a curve in that paper of survival above and below 440. So 440, that's good. And then it gets kind of replicated in other databases. But 440 is different for various people, right? Like for my 6'1", 18-year-old heritable, 440 is horrible. He's predicted as probably 700, but for my 5'1", 75-year-old scleroderma patient, her predicted is probably 370, and there's no way she's ever going to get to 440 based on her demographics. And so I think that's one of the biggest limitations to using these non-invasive variables. So Jimmy had written asking for some cases for discussion. So I'm going to give you these two examples of where I think risk assessment falls apart. So this is a woman, she's 45. I've been seeing her for about 5 years. She has clear-cut idiopathic PAH, was sick on at the time of her diagnosis, was started on triple therapy, and she's done great on triple therapy. She's currently on EPO 44 nanograms, tadalafil and Massey. Last time we saw her, doing great. Functional class 1. She can do anything she wants. Her hall walk is 617, well above 440. Really great. Her BNP was 48. She calculated into low risk by both Four Strata and Reveal. Is everyone happy? Raise your hand if you're happy. You're happy, right? Now are you happy? This is her echo. This is her most recent right heart cath, a mean PAP of 81, a PVR of 16. That's the apical four chamber. You guys probably all recognize this. This is her short axis. Look at that. Would you be happy with that? If you did her risk score and said, oh, you have a 97% 1 year survival and a 91% 3 year survival, would you be happy with that? So I think that's one of the limitations. Here's the other side. This is a woman, I've been seeing her for well over a decade. We have a great scleroderma program at Michigan. They screen everyone. They did detect on her. We met her in 2012. Her hemodynamics, you see there, a mean PA of 33, a PVR of 3.2. We put her on PDE5 monotherapy, and she's been on that ever since. But every time I see her, she's functional class 3. She really can't make it up the stairs without feeling a little short of breath. Her hall walk's 244, well less than 440, right? Her NT or her BNP is 128. Remember, she's 75 now. It's been 13 years since I first met her. You do her risk score. She's intermediate high by Four Strata and intermediate by Reveal. Oh my gosh, we need to do something, right? We need to add. We've got all these tools in our tool chest that Sudhar talked about. She's not meeting low risk criteria. Who thinks we need to do something else? Yeah, you guys are on to me now. So, so you don't raise your hands. This is her echo, right? She's 75 now. Her RV looks beautiful. Her left atrium's getting big. You know, it's 13 years since I met her. Her most recent right heart cath, mean PA of 25, PVR of 1.7. It's her short axis. She's not at low risk, right? People would go through the guidelines and say, I'm under treating this woman. But do you think adding more medicines is going to help her, is going to help her functional class or hall walk? It's not. So these are the limitations of risk assessment, and we are facing this more and more. I think Abby is here today. This is a paper that Abby Palms published from the Reveal Registry, simply showing that patients with comorbidities have more advanced functional class and lower hall walks, right? So their risk scores are influenced by their comorbidities. And we are seeing comorbidities more and more commonly. I always think of the French population as that clean population, but it's not clean. In fact, almost more than half of their patients have at least one comorbidity. And we know from multiple different studies now that comorbidities impact outcomes, that patients with comorbidities are more likely to have a poor outcome, no matter what you do, no matter how you treat them. So I think that needs to be taken into account as we apply the risk assessment scores. And I love this diagram that we put in this paper that Sandeep Sahai was the first author on. You know, this was really a response to the ESC, their 2022 treatment guidelines, having comorbidities off to the right. If they have comorbidities, you treat them more gingerly, because they didn't really quantify severity, number, duration of comorbidities. And, you know, so I think you have to take into consideration the number, severity, and how well the comorbidities are treated, and balance that with how severe the pulmonary vascular disease is. So I can give you more examples, right? I have a 50-year-old woman who has well-controlled high blood pressure, who's diagnosed with heritable PAH with a PVR of 10. her burden of comorbidity is low, her burden of pulmonary vascular disease is high. I don't treat her along the right side of the 22 guidelines with comorbidities. I treat her along the left. And, you all have seen the 75-year-old ladies with hypertension, diabetes, obesity, and sleep apnea who have a lot of comorbidities that maybe aren't well treated and a PVR of 3.2. So that patient has a lot of burden of comorbidities and a low burden of pulmonary vascular disease. So this is part of the problem. The big three: Hall Walk, Functional Class, and NT Pro or BNP. And so, those are the basis of all our risk calculators, but they're probably not enough, right? Like I've just shown you examples of how they're not enough. And this is where I think we need to be going with risk stratification in subsequent world symposia. Now, Sudar showed you this paper. This is from the French group, and this looks at how hemodynamics complement the the four strata risk score. And I was just in Paris last week. I spent some time with the French. They're very lovely people. They don't get echoes. It's so hard to get an echo. It's easier for them to get a right heart cath. So they have a lot of right heart cath data. And here they show you the survival based on the addition of hemodynamics to the four risk strata model. And so this is essentially what Sudar showed you. So what they showed is if you're at low risk, your prognosis is good, and the hemodynamics did not delineate further. Now, I'll qualify the same thing that Sudar did. Their 3-year survival was 91%, which in my 45-year-old woman who calculates the low risk with horrible hemodynamics, she doesn't want to hear that. I don't want to tell her. So that, I think, is a major limitation of this paper. It's only 3 years. And that low risk group, I would in particular like to see followed out more. So I think hemodynamics could be still useful in them. In the high risk patients, their survival was horrible, no matter what their hemodynamics were. But in the intermediate low and intermediate high risk patients, the hemodynamics that were most prognostic were stroke volume index and SVO2. So again, reflections of right ventricular function. And so they stratified that intermediate low and intermediate high risk group further based on hemodynamics. So I do think this is an important complement. Hemodynamics is an important complement to the non-invasive risk stratification. And I personally use hemodynamics and echo a lot to help complement that. Now, hemodynamics are great. The French have easier access to them. Many of us have easier access to echo. So there is more and more emerging data on the use of echo to complement risk stratification. So this is data from the Europeans looking at preserved TAPSE. So the things that are important: TAPSE is important. One of the things that's really important that's not really well studied is how much TR they have. And so in this study, they found that patients with a good TAPSE and non-significant TR had the best prognosis of all, and patients with an impaired TAPSE and a dilated IVC, which reflects right heart failure, had a worse prognosis. So there's starting to be some emerging data on echo. A lot of people are falling in love with this ratio of TAPSE versus systolic PA pressure. And in this study, it's led by a French author, but it's an international study. They found that this was helpful. It's now made it into the European risk table. I have to say that I'm not 100% thrilled with this measurement. I feel like TAPSE is maybe not the most reliable measure of RV function. You're really looking only at one place in the RV, and there's a lot more to the RV function than just where the tricuspid annulus is. And we've all talked for years about the limitations of systolic PAP, right? It's dependent on the jet. Whatever error you make is squared and multiplied by 4. So I personally don't love this one, but it's getting some attention. And then there are others looking at TAPSE and TR again on the left. and TAP-CNTR velocity on the right. And these studies show the prognostic impact of those measurements, but none of these studies that I'm going through with echo looked at it on top of the non-invasive risk stratification. So that's an opportunity we have for further research. Now, there was one paper that I think is really important looking at a Reveal echo score. And this just looked at the echo data they had from Reveal, looking at these four parameters: TR severity, RV dilatation, RV function, and pericardial effusion, and putting that score on top of the Reveal score. And it was useful. Um, Again, some of the limitations with the echo databases that we have are, these are just reports obtained in clinical practice. There's variable information. Not everybody does TAPC. Not everybody does this, that, centrally read echoes would be more useful. But I think it's good that we're going that direction. There's also some data with MRI. RV and systolic volume index is something that is emerging on MRI as important in terms of prognosis. And we have some data using that. Again, most of these have not been studied as a complement to the non-invasive risk stratification, which is really where I think the field is going. So Sudhir showed this slide, and I think it's really important to think about this. It was really the conclusion of the risk stratification and treatment goals task force at the last World Symposium, which, I'll tell you, was the task force that actually had the most fireworks last World Symposium, but in a good way. That's good. So, it has the big three, which we're always going to rely on, but it acknowledges that they're not disease specific and can be potentially affected by other comorbidities, other conditions than PAH, and that some of these goals may not be achievable in those patients. My 75-year-old 5'1" woman with scleroderma. And then it really points out other areas for research, both non-invasively, some echo options at the top and some hemodynamic options at the bottom. And then it really says, maybe we need to be more aggressive. And I think this is a little bit initiated by the sotatercept data that Sudhir mentioned, and I'm sure Kelly will go into more detail. We've been able to lower PA pressure like never before with that therapy, 14 millimeters of mercury in Stellar and Zenith. And so should that be one of our more important goals, really taking the afterload off, getting the PA pressure down? So, hopefully we'll have more and more research in this area. So in terms of the gaps and where we're going, we need to make risk stratification practical for widespread use. The right heart cath data from the French is really important. I think I use right heart caths all the time, but there are a lot of places where right heart caths are done at the time of diagnosis and then they're not repeated, or there are some areas of the world that don't have the resources to do right heart caths frequently. And similarly with echo and even MRI, there's some places who do a lot of MRIs and some places who do them very rarely. I think one of the more important issues is the patient perspective. Every single talk on risk stratification is just exactly what I've talked to you about: the objective scores, what hemodynamics, what imaging can add. And, it's great to say we've gotten someone to low risk and their hemodynamics are X, Y, and Z. But what does the patient want, right? The patient wants to feel good. They don't want to just say, oh, it's great that I'm at low risk. Like, they want to feel good. And we have not been as successful as I would like with incorporating quality of life or patient recorded outcomes in many of our trials and even clinically. One of my biggest beefs with the data we have is that the follow-up is not long enough, especially for those younger patients. And most of it doesn't apply to some of the less common associated types of PAH. So when we think about the big three, we need to think about the other big three, what we really need to inform treatment decisions. And so, yes, it needs to have prognostic value like our current big three does. They're all prognostic, But I also think that it needs to reflect the severity of the pulmonary hypertension, the RV dysfunction, the pulmonary vascular disease, because we needed to really reflect what the disease we're treating, not just that someone is older and has comorbidities. And of course, it needs to be amenable to modification through treatment interventions. So in the future, I think we need to further delineate the role of imaging and hemodynamics as a complement to the current risk scores that we have. There may be novel biomarkers that we've yet to find that can be useful for us, or genomics that may help us predict. And then there's other advanced statistical modeling techniques that are way above my head that may be helpful for us in the future. So with that, I will stop, and I'm happy to entertain any questions. Thank you.
Dr. McLaughlin, thanks for the great talk. Cameron McGuire from UNC. Quick question about, maybe you know the landscape of this, but it's always bothered me that we ordinalize or dichotomize continuous variables in pH. And like you alluded to with your scleroderma patient, sometimes just a small change is sufficient for a patient. Do you know of anyone who's doing patient-specific deltas in some of these outcomes? Like, I've dropped their SPAP by something, or I've dropped their BNP by some percentage change, rather than just some random number that we've decided is a cut point in a survival curve or something.
Yeah, it's a great question. I think it's really hard to do. I'm not aware of any research like that. When you say scleroderma, I also look at Steve, so he may be aware of something. A 40% reduction in the baseline BNT pro.